We are live.
A very good evening, everyone. Welcome to iFocus Online, lecture 238, number 25 in our series from Squint and Pediatric Ophthalmology. Today, we have with us Dr. R. Muralidhar from Eye Foundation, Coimbatore, talking to us on topical diagnosis of paralytic strabismus, syndromes, and the special forms. The chairs for tonight are Dr. Pradeep Sharma sir and Dr. A.K. Amitava sir. I request Pradeep Sharma sir to welcome our speaker and introduce him to our audience.
Thank you, Shefali. It's really a great pleasure to welcome and introduce Rajamani Muralidhar, one of the youngest star speakers in the field of pediatric ophthalmology and strabismus. He did his MBBS from JIPMER, Pondicherry, and then his post-graduation from our RP Center, AIMS, New Delhi. And then he did his fellowship in pediatric ophthalmology, strabismus, glaucoma, and neuro-ophthalmology from Shankar Netralaya. And then fellowship in glaucoma neuro-ophthalmology from Moran Eye Center, New York Eye and Ear Infirmary in USA. Worked as a senior consultant in pediatric ophthalmology and neuro-ophthalmology, Arvind Eye Hospital, and currently in Coimbatore. So you see, he has traveled most of the places which are the pilgrimages of strabismus and pediatric ophthalmology in India. And now he's heading the Department of Pediatric Ophthalmology and Neuro-Ophthalmology at Eye Foundation, Coimbatore. He has many publications to his name in national and international journals. He has been having an active participation in most of the national and international conferences on this subject. It's going to be a real pleasure for all of us to listen to Murli on talking about the topical diagnosis of paralytic strabismus. It will be really a pleasure.
Thank you very much, sir. At the outset, let me thank Dr. Honavar and the iFocus team. iFocus is one of the niche and most coveted of PG training programs, and it's a real honor and pleasure to be here. And I also wish to acknowledge my mentor, Sharma sir. Most of whatever I have learned in strabismus has come directly from him. And thank you, sir, for those kind words. So it's a real pleasure to be here. So I'll be talking on the topical diagnosis of paralytic strabismus. So paralytic strabismus is an concomitant strabismus because of motor deficiency of one or more extraocular muscles. So these are the features: secondary deviation more than the primary deviation, and deviation is maximum in the gaze of affected muscle. So the patient usually adopts a compensatory head posture. I've put restriction of ocular motility way below. The reason is because sometimes restriction of ocular motility may not be very obvious, especially in mild palsies, but the other clinical features help us to diagnose. Floating saccades is a very great value, as is a negative force generation test and a positive force duction test, and eventual spread of committance happens, which could confuse the clinical picture. Not elaborating on these anymore because I'm going to cover these in the slides to come. Note this patient, note the motility of the right eye. So you note that the abduction of the right eye is visibly slow when compared to the left eye. This is because the right lateral rectus is weak. If you could quantify it by video nystagmography, the saccadic velocity is less than 300 degrees per second. And this is a very important feature in helping us diagnose paralytic strabismus, especially in children where a force duction testing may not be possible. Note the abduction saccade of the right eye, which is slow. It is also called a floating saccade. So now have a look carefully at the right eye for this patient. So you note a small nystagmus. This is a gaze paretic nystagmus. Note that the restriction of ocular motility is not very prominent here, but this fine nystagmus that happens here, it's asymmetric. I just had to bring it out by closing the other eye so that I could bring out the maximum abduction. So this is also a very important feature of paralytic strabismus seen only in the paretic eye. It's a very mild sixth nerve palsy brought about by papilloma virus injection. So in contrast, look at the abduction of the left eye here. Note very carefully the abduction of the left eye here. So this is what we call a tethered stop. Okay, so the eye abruptly comes to a stop. This is not a floating saccade. The velocity of the eye till abduction is very good, and then suddenly it comes to a stop as if something is pulling it. So this is a very, very typical feature of a restrictive strabismus. So we have a floating saccade that characterizes a paralytic strabismus, and we have this tethered stop that characterizes a restrictive strabismus. So even without doing a forced duction testing or a forced generation testing, you have now two categories. One is a paresis of an extraocular muscle that is causing the motility dysfunction, and a restrictive. Of course, the two could coexist. Nevertheless, these remain very useful clinical signs. So the most important in all this is whether it is monocular or binocular. If it is monocular, I mean, it's not neuroophthalmic or to deal with pediatric ophthalmology, will not elaborate on this. There could be rarely cerebral polyopias, which are very rare, and neurologists get to see them, we don't. So the others are standard. So what is very important in the history is history of trauma and malignancy. Remember, if you don't ask for history of malignancy in the exam, trauma or an ocular sinus neurosurgery, the examiner is going to get very cross. Okay, of course, the others are also equally important. Malignancy, I would put it as number one because I would cover it in the slides to come. So the strabismus evaluation, as from Sharma sir's book, I've taken this. So you have the cover test and cardinal gaze deviations, and I would cover all this in the slides to come. Ocular motility, I've again put it down because sometimes the restriction of ocular motility may not be very obvious. So this is a very, very important test. So do it under topical anesthesia. This patient has elevation restriction. He actually had a vertical gaze palsy. So do it under topical anesthesia. Remember, this is a forced generation test. The second one, what I'm doing now is a forced generation test, asking him to look up and trying to pull the globe in the opposite direction. Sorry. So remember to lift the globe up. If you retropulse the globe here, you would essentially end up with a false negative forced duction testing. So the interpretation of this test is that the forced duction is negative and forced generation is also negative. There's no superior rectus tug, which means that it is a superior rectus palsy. And the elevation restriction in this patient is a result of palsy of the left superior rectus and not a restriction of the inferior rectus. So the two are totally different, and this needs particular attention. So we covered floating saccades, we covered tethered stop, we demonstrated gaze paretic nystagmus, and also forced duction testing. So before I proceed further, remember that abduction, abduction restriction, before you say that a particular motility is restricted, you need to do the duction testing. Okay, so this patient, has a history of esotropia since birth. Okay, esotropia is there since birth and was referred for abduction restriction. So note that on duction testing, there's hardly any restriction. So you mentioned that there is a restriction in extraocular motility only when there is a restriction in duction testing. So this patient doesn't have any paresis, has infantile esotropia with cross fixation. So now this patient is orthotropic. So the characteristic feature of restrictive strabismus, as Sharma sir always taught us, is that the restriction of ocular motility is not in line with deviation in primary position. So if this patient were to have a left abduction restriction because of sixth nerve palsy, he or she cannot be orthotropic in primary position. So because the patient is orthotropic, this is not sixth nerve palsy. Rather, the history dates since birth. There is an upshoot here. So this patient is an orthotropic Duane's retraction syndrome left side with a co-contraction of the medial and lateral like this. So this patient again has an exotropia with a right abduction restriction. Okay, again a sixth nerve palsy, unless you have meddled with it, given Botox or done surgery, cannot have exotropia in primary position. So this patient doesn't have sixth nerve at all, and rather, if you notice, there is a lot of congestion on the medial side, and when you image it, there is a cysticercus of the medial rectus. So this is very important, restriction of ocular motility, which is not in line with deviation in primary position. If the patient were to have a right sixth nerve palsy, he or she should have esotropia in primary position, not exo or orthotropia, unless you have meddled with. So this patient has an exotropia in primary position, has a right abduction restriction, and therefore patient doesn't have sixth nerve palsy, rather was a restrictive. Remember, this patient is a child, you cannot do a forced duction testing. So diagnosis is based on indirect evidence, may not be able to do forced duction testing. So history is all important. So this patient developed an esotropia when she sustained trauma when traveling in a bullock cart. On deeper questioning, the trauma was not a blunt trauma. It was with a hook that was used to suspend a lantern. So after she sustained injury with the hook, her eyes became red and she became esotropic. So this is her intraoperative picture. showing a traumatic avulsion of the lateral rectus. The injury is because injury is a sharp injury. So patient had an avulsion, and this is after surgery when we managed to fix her. So history is all important in this. And this patient is a pathologic myope. You notice the pseudoproptosis of the globes. So this patient is a pathologic myope. She's not wearing glasses because she has undergone ICL surgery. So this is a very important differential diagnosis. The patient has a heavy eye syndrome. Notice the superior rectus displays nasally. Note the lateral rectus displays inferiorly. And these two arrows here, these two arrows refer to the stretched LRSR band. So this patient has a heavy eye syndrome in the right eye with esotropia, and that is causing the abduction restriction. So this is after surgery, may not be relevant to this talk. So now we come to the right sixth nerve palsy, which is what we normally associate with an abduction restriction. So these are the clinical features. So esotropia is maximum on gazing to the side of the palsy. This is the most important thing. So I will demonstrate this by means of slides. Remember to mention the abduction restriction only on duction testing. So this patient, if you note, with right eye fixing, has a large left esotropia. With the left eye fixing, the esotropia is small. So secondary deviation is deviation with the paretic eye fixing, which is the right eye fixing. And so the right eye is the paretic eye. With the normal eye fixing, the deviation is hardly there. This is one of the characteristic features of a paralytic strabismus. So other things are you can have a small V pattern. Normally we say the V pattern is significant only when it's a 15 prism diopter. Sometimes there could be a small V pattern because of medial rectus overaction. Medial rectus is more effective in down gaze, so that could be there. And because the lateral rectus causes divergence, so deviation is more for distance. So sometimes you can have a small esotropia for distance, whereas patient will say there is no diplopia for near. So unless you measure for distance, you may miss the sixth nerve palsy. And sometimes the deviation could increase in either gaze, so could represent a bilateral sixth nerve palsy. Vertical tropias up to 3 PDs are permitted, possibly because of decompensation of a pre-existing fovea. So now if you look at this patient came complaining of double vision. But if you see, there's hardly any motility restriction. And so here is why your cover test for distance. Please note for sixth nerve, you need to do a cover test for distance. So note the esotropia here. So esotropia is increasing on gaze to the right. And it's also increasing on gaze to the left. Okay, so if you note here, there's hardly any movement restriction. So this patient essentially had a bilateral sixth nerve palsy. MRI was normal and possibly followed post-COVID. She never tested herself, but many people in her family had this flu type of illness. MRI was normal. So this is a very important sign. So this patient has a left sixth nerve palsy, not the abduction restriction here. Patient has ptosis and also has a small meiosis. So this is what we call the Parkinson's sign. That is association of Horner syndrome with sixth nerve palsy. So please note, we don't have access to cocaine eye drops. So diagnosis is largely clinical, but you need to know the pharmacological test for Horner syndrome. It's an important exam question. So this patient has ptosis, and this patient mild meiosis, not very evident in this photograph, but had a more meiosis, which was more prominent in dark. So we, and corneal sensation was also impaired. So we localized the lesion to the cavernous sinus. And true enough, this is the cavernous sinus on this side, which is the left side. This is the cavernous sinus on the right side. This black thing is the internal carotid artery. Note this cavernous sinus is bloated up. The patient had a the radiologist made a diagnosis of a Tolosa-Hunt syndrome. So beware of misleading information. This patient, one of our residents got it. The patient was staying in a hostel and was very clear in his history that he had double vision for 2 years. So Duans very rarely can, but very rarely presents with double vision. So patient is saying that has double vision for 2 years without undergoing any surgery or whatever intervention. So it means the double vision is for 2 years only. So had double vision for 2 years, we are possibly looking at an acquired right sixth nerve palsy. What my resident pointed out was this possibly is a preauricular tag. This one, the small thing on the pinna. So I said this is not a preauricular tag, it's very much on the pinna. Patient is saying double vision for 2 years. So this is not a Duan syndrome. So this is very much a sixth nerve palsy. We had to get a CT done because patient couldn't afford it. So patient turned out to be having a sphenoid wing meningioma. Okay, so beware of all this misleading information. Even if the patient had a preauricular tag, says double vision for 2 years, please take it seriously and do get this patient image. MRI is the investigation of choice. So this patient has a left sixth nerve palsy, and note the wide palpebral fissure on the left. I had also a mild, I had an eye squeezing somehow. The lag of thalamus is not very evident on this, but the palpebral fissure is definitely wider on the left side. Had a left sixth and seventh nerve palsy. So you have to get this patient image more so, and you put the diagnosis somewhere in the pons or the CP angle, which is where the sixth and seventh nerve bundle up together. So patient had a schwannoma in the prepontine system. This is the pons. This is the cerebellum, not the folia of the cerebellum. This is the floor of this is the fourth ventricle, and this is the implicating lesion, schwannoma, which is causing the sixth and seventh nerve. So this patient, notice him squeezing the eye. Patient came with a history of double vision and headache. So notice that the squeeze is less evident on the left side. Vision was good. Patient had bilateral disc edema and increasing esotropia to the left. I'll show a video. Had a left seventh nerve palsy, corneal hypoesthesia, and Brunn's nystagmus, very typical Brunn's nystagmus. So just have a look here. So notice the esotropia. Notice the esotropia. The movement restriction was not very typical. Patient is ortho and right gaze. So this is very important. So deviation increases in direction of action of the parietic muscle. We are doing the cover testing for distance. For near, he may be ortho. So notice the large amplitude nystagmus. I'll show you in a separate video also. So the nystagmus now has become large amplitude. So give him some time to fix. And notice this. So patient has gait ataxia. So he's not able to do tandem walking. He has gait ataxia. He is esotropic to the left side, has bilateral disc edema, corneal sensation is lost. So everything, it's a very textbook picture of a CP angle tumor, not the Brunn's nystagmus. So large amplitude, low frequency nystagmus on the side of the lesion. When he looks to the right, it's a very fine amplitude, high frequency nystagmus, very fine amplitude, high frequency nystagmus. So it's called the very typical Brunn's nystagmus. On the side of the lesion, large amplitude. So notice a very important clinical sign, large amplitude, low frequency nystagmus. And when the patient looks to the right, it's a high frequency, low amplitude nystagmus. So very, very textbook picture of a CP angle tumor. So patient had a huge CP angle tumor and recovered completely. And this is an obstructive hydrocephalus. So notice the dilate. This is the temporal horn of the lateral ventricle that is also dilated. So if the temporal horn of the lateral ventricle is dilated, that means it's a hydrocephalus, and it's an obstructive hydrocephalus. This is the third ventricle. So it is causing obstruction of the aqueduct of Sylvius. So the third ventricle, lateral ventricle, everything is dilated, and you have a huge mass sitting on the left, CP angle. So very textbook picture. Sometimes it is not that classic. So now, note this 40-year-old who came with complaint of double vision has a left abduction restriction. So this corneal sensation, it is very, very, important. So notice patient has absent corneal sensation to the left, on the left side. I'm sorry, I think it just got covered. I'm truly sorry about this. This thing got messed up. Yeah, so the patient has a left corneal sensation along with a left corneal hypoesthesia along with a left abduction restriction. So we are looking at a left a lesion in the cavernous sinus. So if there are orbital signs or if there is an RAPD in association, you would possibly be thinking of a superior orbital fissure lesion. But then this distinction, it's an anatomic continuum, the cavernous sinus and the superior orbital fissure. So the distinction is largely artificial. So this patient has an inflammatory mass in the cavernous sinus, and which is causing the left sixth nerve palsy. So now it could be a very dangerous sign. So this patient had a history of oral carcinoma. So note the oroantral fistula. Okay, this was before he was given radiotherapy, and he received 14 cycles of chemotherapy a year back. And this was a CT scan when he had the cancer. So this is the oral cavity. This is the antrum of the maxillary sinus. Both of them are linked, and they healed after radiotherapy, and after giving some 14 cycles of chemotherapy, he came with double vision. Okay, so notice that this patient is orthophoric for near. So unless you give the patient a distance fixation target, you may miss the sixth nerve palsy. Incidentally, he had an abduction restriction, not very obvious on abduction testing, which is why I have put only the version photographs. So notice patient is ortho on left gaze. Please note that patient may sometimes be adopting a small head posture. So if you don't correct the head posture or do a near cover test, you're going to miss it. So particular point for the exam, correct head posture if any, and do a cover test for distance fixation. Patient has a esotropia, which is increasing to the right. And notice that he measures 9 PD base out in up gaze and 12 PD in down gaze. So this was the small insignificant V pattern which I was talking about. So we got the MRI imaging done. And notice this is the, I'll show the anatomical structures. I hope you are able to see my arrow. This is the ethmoid sinus. This is the sphenoid sinus. Okay, this is the this part is the cavernous sinus, which is thickened on the right side. This is the left cavernous sinus normal. This is the right cavernous sinus, and this is the left. I'll just see. So notice this. This is the right cavernous sinus, which is thickened. Okay, and this is the left cavernous sinus, which is normal. So this has already been marked by the radiologist, so this patient had a perineural metastasis. Perineural metastasis into, I don't know how to get my arrow. This patient had a perineural metastasis along branches of the fifth nerve into the cavernous sinus. So history of malignancy should alert you immediately. Do get these patients imaged. MRI with contrast is the investigation of choice. And notice this patient has a left abduction restriction. Notice the proptosis on Nafziger's testing, and notice also the small ptosis. So here we are looking because orbital, there is a proptosis also, and because retropulsion, we were not able to push the globe back. We thought that this possibly was a superior orbital fissure to orbit with orbital extension, and true enough, he had a huge tumor which was extending into the orbit, causing orbital signs as well. So please look for orbital signs too when you're dealing with a patient with cranial nerve palsies, which concern the eye. So now we have a 60-year-old. Notice this is a very classic patient who fell off the two-wheeler and bumped her eye. And this was the picture that we got. So movements restricted everywhere, global ophthalmoplegia. Remember, in this patient, you are not supposed to do a force duction testing. If you do a force duction testing, you might invite a lot of trouble. Notice this pulsating proptosis. You really have to, it's not that classic. So but I'm sure you can appreciate this is a pulsating proptosis. So we are dealing with a classic sign of caroticocavernous fistula. Please remember, as the exam question, avoid doing force duction. What should you not do in a caroticocavernous fistula? The answer is avoid doing a force duction test. Right. So now, so now this is a patient who has a left abduction restriction. He had a history of stroke. So notice how we are able to guide the radiologist and predict the site of the lesion. So we have a sixth nerve palsy here. And then look here, the patient is attempting to do tandem walking. So not able to do tandem walking, he's grossly ataxic. He's grossly ataxic. And now we are looking at possibly a lesion somewhere in the pons, because the middle, there is a middle cerebellar peduncle there, and the sixth nerve comes out through the from the pons. Sixth nerve comes out from the pons. Patient didn't have a facial nerve palsy, but given the gait, ataxia, and the left sixth nerve palsy, we possibly would be looking at a lesion somewhere in the pons. So you need to know your neuroanatomy basics if you want to localize this. But note this very, very interesting clinical feature which we also published. So the patient was asymptomatic, recorded on slit lamp. So at the whenever the patient attempts to make a horizontal saccade, notice the torsional, inappropriate torsional eye movement. This was present in both the eyes, conjugate in both the eyes. Patient never complained of any oscillopsia. So this is a very, very typical dorsipulsion, which puts the site of lesion as the pica, in the pica territory. Pica meaning posterior inferior cerebellar artery, that is in the dorsolateral medulla. Okay, so you have a patient with left sixth nerve palsy, with left dorsipulsion, I'm sorry, just dorsipulsion and gait ataxia. So we are possibly looking at a lesion in the dorsolateral medulla and the pons. So that is what we told the radiologist also. And remember, your neuroanatomy never fails you and your clinical skills never fail you. So let me just use the highlighter. And see, this is the dorsolateral medulla. Okay, this is the dorsolateral medulla, and this is the pons. So you were able to localize the lesion and guide the radiologist. Okay, so this is the dorsolateral medulla. You have an infarct, and you also have an infarct in the pons, which is involving the middle cerebellar peduncle. Okay, which is involving the middle cerebellar peduncle. So you were able to localize the lesion merely by looking at the having a careful clinical examination. So a careful clinical examination together with history is what guides you through this paralytic strabismus. So now notice this, and this is also a very important exam question. Patient had a head injury. So patient has a left abduction restriction with intact convergence. Okay, so I'll play the video again. Notice left abduction restriction, nystagmus in the abducting eye, and improved adduction on attempted convergence. So patient has a left internuclear ophthalmoplegia, more precisely a posterior internuclear ophthalmoplegia, because convergence is intact. If convergence is impaired, you call that a anterior internuclear ophthalmoplegia. So this is also an exam question. So patient had a head injury, and notice this very, I mean, unless you tell the radiologist, he's not going to look for it. So notice a very, very tiny medial longitudinal fasciculus lesion. So you need to make this diagnosis. So this patient has a left posterior internuclear ophthalmoplegia. So talking of internuclear ophthalmoplegia, you have something called the Webino. Webino is wall-eyed, looking towards the wall. Wall-eyed bilateral internuclear ophthalmoplegia. So this is also a posterior internuclear ophthalmoplegia. Notice that notice here the adduction is restricted. Notice here the adduction is restricted, but convergence is intact. This patient had a binge drinking. So we postulate the MRI was normal. Okay, the MRI was normal. So we postulated that this possibly could be because of vitamin B deficiency, possibly thiamine. So we gave him a good shot of vitamin B, and the patient recovered fully without sequelae and want him to stay away from drinks. So now we come to evaluation of third nerve palsy, which is very, very important, more so from exam point of view. Notice that in this patient, there is ptosis and the eye is deviated in complete third nerve palsy. Eye is deviated down and out. So, so this is the classic textbook picture. The abduction is normal. The adduction is hampered. Elevation is hampered. This is a complete third nerve palsy we are looking at. The elevation both in abduction and adduction is impaired. And the depression is also impaired. Okay, so this is a complete third nerve palsy. So what we really need to look at here is pupils. Okay, pupils I have not mentioned. I just thought I'll show in pictures. So you need to know whether the globe is crossing the midline, the saccades, the FDT, and partial complete. There are two signs which I want you to see. I have not mentioned it here. So one is the aberrant regeneration. So you do need to look at the aberrant regeneration. Note when the patient is attempting to look down, when the patient is attempting to look down, you have this lid retraction. Okay, so pseudo-vonography sign, very, very important. This means that this is not a medical third nerve palsy that you're looking at. Instead, you are looking at possibly something surgical. You need to get these patients imaged. What imaging? I'll just come shortly. So this is another very, very important thing. Notice the left, I'll play this video again. This patient has a left third nerve palsy. So note that the Z-axis passes through the temporal limbus. So the only way to check superior oblique function, it is very important to know whether superior oblique is involved or not. Because superior oblique is also involved. That makes it a third and fourth nerve, double cranial nerve palsy. Otherwise, only the third nerve is involved. So notice this intorsion. You have to look at a vessel in the superonasal limbus. So note here. So there is an intorsion when the patient attempts to look down. It is superonasal limbus. If you look at the temporal limbus, you are likely to miss it. Okay, so patient has to, you have to have a look at the superonasal limbus. Okay, so that is very important when checking for intorsion. So this young lady, any young patient presenting with third nerve palsy, close your eyes, send this patient for imaging. Imaging of choice is MRI with contrast and CT angiography when the suspicion of an aneurysm is high. We got an MR angiography at that time, but nowadays we send for MRI with contrast and CT angiography. Very typical PCOM aneurysm. Okay, very typical PCOM aneurysm. And this is what this is how a CT angiography looks like. Okay, this is how a CT angiography. Note the clarity. Clarity is simply too good. So it is not digital subtraction angiography anymore. It is CT angiography, which is the investigation of choice for pupil involving third nerve palsy. So complete pupil involving third nerve palsy. Now note what to do for partial pupil involving third nerve palsy. Partial pupil involving third nerve palsy. I say this is partial because this is a left third nerve palsy. Notice the ptosis here. So the reason why I am saying that this is a partial third nerve palsy, note that the depression is intact. So part of the third nerve is spared, but if it is pupil involving partial or complete, send for investigations. And note that the pupil is also involved here. Pupil is also involved here. So we send for investigation. Note that there is a huge saccular aneurysm of the internal carotid artery in the intracavernous part. Okay, internal carotid artery in the intracavernous part. So the point is, if there is a partial pupil sparing third nerve palsy, follow these patients up initially every day to look for pupil involvement. So pupil involvement is the most important sign in third nerve palsy, and aberrant regeneration is the other important sign. So now what to do for this patient? So this patient has a complete third nerve palsy, pupil sparing, no aberrant regeneration. Note there is ptosis, the globe is deviated down and out, elevation. So elevation is restricted. I'm sorry. I'm so sorry. I'm sorry. I should have put it in the right side. Elevation is restricted, and so is the depression. So ignore this. It's on the right side. Right side. So now this patient had a pupil sparing, no aberrant regeneration, totally uncontrolled diabetic, and this is what happened after a month. So if you have a third nerve palsy that resolves, let us say, which is pupil sparing and there is no aberrant regeneration, so you could elect to observe. But if it is a young patient, young meaning less than 50, without any atherosclerotic risk factors, go ahead with MRI with contrast and CT angiography. But in this patient, of course, there is a full recovery. There's no need for any imaging. So we elected to observe this patient because she was an uncontrolled diabetic, and also because she was in 60 plus age group, pupil sparing, no aberrant regeneration, no other neurological signs. So we observed her. Notice this. This was how she looked, and this is how she recovered on its own. We have not done anything other than sugar control. Now, just a note of caution here. So all that is down and out is not necessarily a third nerve palsy. So this patient was referred because the MRI and MR angiography was completely within normal limits. So, and the patient complained of double vision for past 2 years. Notice the pearl here, which Sharma sir always tells, that if the restriction of ocular motility is not in line with deviation in primary position. So the patient, the eye is deviated down and out, adduction is normal. Okay, so rather adduction should be impaired. So if you notice here, down and out deviation, but adduction is normal and abduction is impaired. So we are not looking at third nerve palsy. In third nerve palsy, adduction would have been impaired and abduction would have been normal. So it is the other way around. So we are not looking at third nerve palsy. The pupil is not involved either. So here we fall back on the forced junction test, which was very, very strongly positive. So we requested the radiologist, please have a look at the orbit. And this was what we got. So this patient had a cysticercus of the inferior rectus, cysticercus of the inferior rectus. So your clinical signs go a long way in guiding the radiologist as to where to look for the lesion and localizing. So we now touch upon vertical strabismus. So vertical strabismus Parkes 3-step test is very, very important for your exams. So there are some fallacies of the Parkes 3-step test. I have decided to include some slides that show the fallacies. So note now, this patient has a right over left, that is right hypertropia. Okay, so this is a right hypertropia. So we say right hypertropia, not a left hypotropia, because right eye is the non-fixing eye. So whichever is the non-fixing eye, you say that is hyper or hypo. So the right eye is up, R by L, right? Hypertropia. So it assumes that it could be because of weakness of the right eye depressors. I always tell my resident to have this diagram in hand. So it could be because of weakness of the right eye depressors, right inferior rectus and right superior oblique, or weakness of left eye elevators. So now of the 8 extraocular cyclovertical muscles, you have localized to 4 just by looking at whether it is R by L or not. So now you go to the next step. The R by L it is increasing on left gaze. So there you go. The right eye has gone up a little more. I also have a video to show this. So now you localize to two muscles, either the RSO or the LSR, because these are the two muscles in left gaze. Among the 4 cyclone vertical muscles that you chose, these are the 2 muscles that you have narrowed down to. So now you do the head tilt test. That is the third step, Bialshevsky's head tilt test. So notice that there is a right hypertropia on right tilt, and on left tilt the eyes have become ortho. So you have a mnemonic which says superior same side. So now you have localized. So now you have localized to the right superior oblique. So the right superior oblique is the involved muscles. There are some fallacies. One obvious fallacy is that it assumes that the hyper or hypotropia is because of weakness of extraocular muscle, which may not always be true. So now I have a small video to show this. So you have a R by L here. Same thing. I chose the same R by L. So now notice the patient is ortho in right gaze. So on left gaze, you notice that the R by L has increased. So now you have localized to RSO or LSR. In the second step, it is always superior, superior or inferior, inferior. So now we do the head tilt test. Left tilt, ortho, and right tilt, the hyper increases. So remember the mnemonic superior same side. So you have from 8 extraocular muscle, you have localized it to the RSO. Okay, so this is how you test for torsion. There is some controversy regarding whether you should use 2 red medox rod or white medox rod. But if you use 2 red medox rod, the involved eye in this patient, the right eye, should show an extorsion. Okay, so that is why I have rotated this a little out. So notice this, you give the patient 2 pens. So yeah, so this is how it looks like. So patient is tilting the left pen. So when you rotate it, the patient makes it parallel. So right eye is the higher eye, and the red pen is the lower image that you get. Okay, as you extort that, the patient says it is parallel. So the right globe is extorted. This is also a very, very important thing, because sir wanted me to cover about skew deviation. In skew deviation, it is not the hypertropic eye that is extorted, it is the hypotropic eye that is extorted. So the other thing is that you get a lot of brainstem signs. You rarely make a diagnosis of skew deviation. You could have an ataxia, you could have a hemiplegia, or you could have the dorsipulsion that I showed you. The deviation typically disappears in supine position. Okay, the deviation disappears in supine position. So these are the 3 clinical features that could help you diagnose skew deviation. So this is a very important thing. I just chose to include this. A trivial blunt trauma. This patient has a head posture. So note that the right depression is restricted. Patient just bumped against a flower pot. In children, orbital fractures are called white fractures. So pay attention to this. And because the right depression is restricted, so the right depression is restricted here. And so we got a CT scan. Don't ask for an MRI here. You want to see the bones. So ask for a CT of the orbit. So the classic teardrop sign. Remember, if the inferior rectus is entrapped behind the equator, you get a depression restriction. You get an inferior rectus palsy. If it is entrapped in front of the equator, the elevation is restricted. Okay. So, I mean, of course, this is after surgery. So note how difficult it is to note how difficult it is, unless you examine carefully. This patient had a very, 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 very trivial trauma, but mother was categorical. The head posture followed only after that. I'm sorry. So ask the patient to look down. So notice what happens. The right depression is restricted. Okay, the right depression is restricted. Very, very important clinical sign. So immediately, because of history of trauma and trauma to the eye, we got a CT scan done, not an MRI of the orbit. And notice this. Let me just show this. I think I should have had a little magnified picture. Notice this blowout fracture behind the equator of the eye. So this is the right eye. And if you notice here, this prolapse herniation of orbital contents into the maxilla. Okay, so now fractures, there is a blow-in fracture. So fracture of the roof of the orbit. So this can also cause an elevation restriction here. So, and this is the fracture seen on axial cut. So now notice this very, very important clinical sign. So if you notice here, patient is ortho in primary, ortho in upgaze, but in looking directly down, patient has a esotropia. This is called an arrow pattern esotropia, very, very typical of bilateral acquired superior oblique palsy. So if you get an arrow pattern esotropia, we are looking at a superior oblique palsy. So this is after surgery. And this patient had a Bulgor injury. So the diagnosis is written all over. Note the inferior rectus popping out, and the patient had an inferior rectus avulsion. People say avulsion is an outdated term. This is after inferior rectus retrieval. So notice that there could also be something called a flap tear. We thought this was this patient has a right inferior. You see the inferior rectus avulsion following injury with a bag hook that is suspended on many of our two-wheelers. So the patient has a depression restriction, and notice this small tissue popping out, had a sharp injury. Okay, so notice this depression restriction pre-op, and this has improved after surgery. So we got the MRI done here. Because it's a sharp injury, we are getting an MRI done. If it was a blunt injury, we would be getting a CT done. Okay, notice this partial injury called a flap tear. So actually what is hanging here is the orbital layer of the extraocular muscle. So we simply excise the orbital layer, which was acting as a mechanical restriction, and the depression was restricted. So mode of injury, you are unlikely to get this in the exam, but trauma is could be a long question for you. So I thought this would be relevant, that it would be relevant that I cover this. So now this patient came with acute vision. This patient didn't complain of double vision, but came with acute vision drop in the right eye. And notice the disc edema here. Patient had an RAPD. And notice that this right elevation is restricted here. So diagnosis was optic neuritis, and the superior rectus sheath is fused with the optic nerve sheath. Notice that this optic nerve, notice this hyperintensity along the entire length of the optic nerve, which is what is causing the elevation restriction here. So again, history and clinical signs are very, very important. So as I said, history of sinus surgery is very important. Note this patient has elevation, has adduction, and has depression restriction. So this was following FES. Once again, it's better to have a CT scan because there could be some bone injury. I take this opportunity also to cover the Hess chart. So in the Hess chart, the abnormal eye is the eye with the smaller square. So if you notice, this is the eye with the smaller square. The right eye is the abnormal eye, which is showing adduction restriction, elevation and depression restriction. We got, as I said, in following FES, it is better to get a CT scan done and let the radiologist decide if he wants an MRI. So there is violation of the medial wall, possibly of the fat plane also. So the medial and inferior rectus have fused together. See, you're seeing only part of the globe here. So this is behind the equator. Medial and inferior rectus are fused together, which is causing the motility restriction. So sir also asked me to cover the double elevator palsy. So notice in double elevator palsy, the elevation is restricted both in abduction as well as in adduction. Okay, here and here. But the other important, there could be an associated ptosis, but depression is not restricted. That distinguishes it from third nerve. The adduction is not restricted. And notice this Bell's phenomenon here, because it's a supranuclear palsy, the Bell's phenomenon is intact. So this is what distinguishes double elevator palsy from a third nerve palsy. Bell's may not be that great if the inferior rectus is contractured, which is why I mentioned the other signs also. That is, the depression is normal, the adduction is normal. There may or may not be ptosis. So this is a patient with a double elevator palsy, also called a monocular elevation deficit. So sir wanted me to cover the double depressor palsy, very rare. The reason why double depressor palsy is rare is because you need to have right inferior rectus and right superior oblique palsy. In this patient, you can notice that the right eye depression is restricted in dextrodepression. So right eye depression is restricted in both dextrodepression. I'm sorry. Yeah, it is restricted in both dextrodepression and in levodepression. So it is a deficiency of depression. The vestibulo-ocular or Dahl's reflex is intact and usually congenital, but can also happen by lesion of the rostral interstitial nucleus of medial longitudinal fasciculus. Caloric testing may also help. Reason why it is rare is because you need the right inferior rectus supplied by the ipsilateral third nerve nucleus, and you need the right superior oblique, which is supplied by the contralateral fourth nerve nucleus. So because you need two tiny lesions in two separate locations on both sides of the brainstem, so it is undoubtedly very rare. I have taken this from a journal which had quoted this. So so this patient developed frozen globe. Okay, frozen globe, you notice elevation restricted, abduction, adduction, and depression also restricted. Patient had an RAPD, was PL negative in this side. So notice the anatomy of the superior orbital fissure and how this tendinous ring divides it into three parts. So this anatomy is reproduced in a CT scan. So we ask for a CT scan because here again, CT with few MRI cuts if required, because we are thinking of a bony injury, because you have a traumatic optic neuropathy and a traumatic complete external ophthalmoplegia. So we are looking at possibly a bony injury in the superior orbital fissure given a history of blunt trauma. So we ask for CT. Notice there is a bone fragment that is compressing. There is a bone fragment here. Notice bone fragment here, which is compressing, which is dropping into the superior orbital fissure and is causing this palsy, as well as a traumatic optic neuropathy. The strategic location that is causing trouble both in the superior orbital fissure as well as in the optic nerve. So now we come to syndromes. Okay, so this patient presented with history of strabismus and poor motility in the left eye since birth. Okay, so it is there since birth. Possibly I would not have gotten imaging done. The diagnosis is unilateral fibrosis of the extraocular muscles. Post-section testing was also positive, but because the person who referred me already got this MRI done, nothing wrong in getting it done. You can classify this. This is a CT scan which is done. Notice the paper-thin extraocular muscles on the left side. Notice this. Okay, notice this lateral normal medial rectus here, and notice this paper-thin medial rectus here on this side. So all the muscles are atrophic. So we are looking at a congenital fibrosis of the extraocular muscles on one side. Okay. So this patient has Parkinson's. So when you are thinking of Parkinson's and there is an ocular motility restriction, you have three possibilities. Most common is the progressive supranuclear palsy or Steele-Richardson-Olszewski syndrome. Notice in this condition, the vertical motility is affected. Eventually, everything gets affected. So vertical movements are impaired. Many times even the dulls is gone. But horizontal motility is preserved. Okay, horizontal motility is preserved. So patient is a known patient of Parkinson's. So you have to get an MRI imaging done. There are three syndromes. This is a progressive supranuclear palsy or Steele-Richardson-Olszewski syndrome. So in my DNB exam, the examiner actually asked me, and it is given in Kansky also. So you should know this is a normal MRI. Notice the contour of the midbrain. Notice the contour, the convex contour of the midbrain, and notice the dorsally flattened contour that is seen here. So like a penguin silhouette. Okay, this is a penguin silhouette sign on MRI. So if you diagnose progressive supranuclear palsy, you are essentially there is a 100% mortality in 4 to 5 years. Okay, so most of the death happens by aspiration. So it's very important that you localize the lesion, you suspect what you're looking at, and you tell the radiologist. There is a dorsal flattening, so you're looking at a progressive supranuclear palsy. And notice this is a normal midbrain. Okay, this is a normal midbrain, how a normal midbrain looks like. And this is a Mickey Mouse sign because of midbrain atrophy in progressive supranuclear. Same patient, midbrain atrophy. This is a Mickey Mouse sign. Okay, a Mickey Mouse sign, a Mickey Mouse sign. So this is very important, penguin silhouette sign and Mickey Mouse sign. The others are multiple system atrophy and diffuse Lewy body disease, and that the whole brainstem is atrophy. Okay, so a movement restriction in a Parkinson's patient needs to be taken very seriously. So notice this again. I mean, I have already shown you this motility restriction. So the reason why I said is because the etiology is different, and the so notice the left adduction restriction. Okay, the abduction in the notice the left adduction restriction, which improves on convergence. There is abduction nystagmus in the right eye. So this patient didn't have a history of trauma. So very important, because notice here we are looking at a lesion in the we are looking for a lesion in the medial longitudinal fasciculus. This is the medial longitudinal fasciculus. This is a demyelinating lesion. Okay, patient recovered fully after IV pulse steroids. Okay, so this is a demyelinating lesion. So you have a left internuclear ophthalmoplegia, and this is what we have. Okay, so I would, can I play this video from outside? Do we have some 5 minutes more?
Yes, sir. Sure. Go ahead, please.
Okay. So just give me 1 second. I hope it plays.
Right now, it's not playing, sir. Are you playing it from outside, sir?
Yeah. No, it's not playing. I'm very sorry. Okay, I'll see if I can play it at the end. So I'll just show the sign. You're able to see the slide, no? So patient has a horizontal gaze palsy. I'll try to play the video at the end if we get time. So this patient has what we call a split pons sign. Okay, pons is where the parapontine reticular formation, which controls this thing. So you have a cleft in the floor of the fourth ventricle. There is an arrow here. So this patient has a horizontal gaze palsy with primary progressive scoliosis. Patient didn't have scoliosis because patient's medulla was normal. So you have to look at the medulla also. So if you have a horizontal gaze palsy, pons is where you look at. This patient has a split pons sign. I'll try to play the video at the end if plays. So now notice this hatchet facies. Hatchet is an axe. Okay, because of atrophy of the facial muscles, maxillary and mandibular muscles. Notice this thin face, hollow temple, ptosis, frontal balding. Patient has pes cavus, is wheelchair bound, and so notice this myotonia. Okay, you percuss on the muscle, there is myotonia. Notice after an attempted hand grip. So after an attempt, there is myotonia, and then there is warming of. When you ask the patient to do it up again and again, the myotonia recovers. So the typical question here is what is the sound you get on EMG? Diagnosis by EMG, you get a diver bomber sound. So they are prone to heart block, and cardiac evaluation is a must in these patients. So in exam, important for you, you can get Christmas tree cataract, ptosis, and watery eyes. So notice this patient who presented with red eye. I had seen him on 2 occasions before and treated him with vasoconstrictors and artificial tears and whatnot. But this time, I mean, the OPD was less busy and paid more attention. So notice this. So notice this head thrust. So it is for both vertical and horizontal. Okay, both the vertical and horizontal. Patient is not able to make fast eye movements. Patient thrusts this, and this telangiectasia doesn't respond to anything, vasoconstrictors, olopatadine, or steroids or whatever. So notice the head thrust, which is present both for horizontal and vertical eye movement. And notice this ataxia, gait ataxia that the patient has. We're looking at ataxia telangiectasia. Okay, so so this patient has what we call a secondary oculomotor apraxia, both in vertical and horizontal plane. Whereas contrasted with this video here, patient has head thrust. Okay, patient has head thrust because patient is unable to make fast eye movements. MRI imaging is mandatory in all these patients. So this is only for the horizontal plane. For vertical plane, patient is able to look up and down. Usually resolves spontaneously if MRI is normal. See, notice that vertical patient doesn't have a problem. Whereas horizontal is impaired. So if MRI is normal, usually the spontaneous resolution is the rule by first or second decade. So this is the photograph of this patient as we travel down. Notice the progressively increasing frontal balding, and notice his brother, which are typical hatchet-shaped faces. And notice after a typical hand grip, the myotonia. So this patient has myotonic dystrophy coming in its myriad presentation. Variable expressivity and autosomal dominant inheritance. So diagnosis is important because you need to get a cardiac evaluation in this patient. Patient can have ophthalmoplegia and ptosis also. And this is a very typical combination. If you have ptosis and lag ophthalmos, that is weakness of the LPS, levator palpebrae superioris, and orbicularis oculi. There are only 3 conditions that can produce it. So notice this. This is one of them. There is lag ophthalmos, bilateral ptosis. So notice the slow saccades. and typical myotonia. Myotonic dystrophy is one of the conditions that can produce both ptosis and lag of thalamus. Ptosis and lag of thalamus. The other two conditions are myasthenia gravis and CPEO. So chronic progressive external ophthalmoplegia. So this patient, typical Duane's retraction syndrome patient. So he underwent strabismus surgery. He was keen to have strabismus surgery with cataract surgery. So we did that. But this was what happened. The patient presented with a complete ophthalmoplegia. Okay, complete ophthalmoplegia around 10 days after the surgery was done. So complete ophthalmoplegia. The patient also had corneal hypoesthesia. There was no proptosis or RAPD, possibly lesion in the cavernous sinus. So note this filling defect in the cavernous sinus. So note this is the filling defect in the cavernous sinus because of cavernous sinus thrombosis. This is a normal cavernous sinus. Okay, normal cavernous sinus, how it looks, and this is a filling defect after contrast administration. Patient had a cavernous sinus thrombosis, couldn't afford MRI. MRI is the investigation of choice. And notice that the elevation, the depression, and the adduction has come back after he got treated for it by a neurologist. Okay, so now we have to think of, we have to look at Kearns-Sayre and CPEO. I didn't cover myasthenia. I have a separate presentation on that. I mean, we could cover it if there is some time because it's a huge presentation. Myasthenia is the third condition that can produce ptosis and lag of thalamus. So this is also another condition. So notice this. The classic clinical picture is that it is insidious in onset, usually symmetric, and so slow in onset that even if there is an asymmetric involvement, this is a symmetric involvement. Even if there is an asymmetric, rarely patient complains of double vision. So you have ptosis, you have lag of thalamus, and you have extraocular motility restriction, which is usually symmetric with negative FDT. And if you get an imaging done, so notice all the extraocular muscles are very, very thin. So diagnosis is by demonstration of red ragged fibers on a quadriceps muscle biopsy. Important, the reason why we should do that is because these patients are prone to sudden cardiac death. Of course, you also need to estimate their lactate levels, which may or may not be normal. They have to be sent to the general surgeon to get a quadriceps muscle biopsy to demonstrate red ragged fibers on electron microscopy. So notice this very, very classic ocular motility restriction. This is a convergence retraction nystagmus, not a true nystagmus, but still called a nystagmus. When the patient attempts to look up, so this is seen in Parinot's dorsal midbrain syndrome. Okay, Parinot's dorsal midbrain syndrome. So this is the dorsal midbrain, not the lesion here. Again, an MRI is the investigation of choice. Sometimes for cost reasons, we get a CT scan done. So, and thank you so very much. Now, if we have just one more minute, I would try to play that if it really plays. Do we have one more minute, Dr. Shefali?
Yes, sir. Sure, please.
Yeah, I'm just trying to play.
Sure.
If it plays, well and good. If it doesn't, I'm sorry, because it is an old format and it is not recognizing it. So I think I'm sorry if I get it. I think we can go with the discussion, and if I'm able to play it in between, I would try. So that was the last of my slides, and because I have a separate on myasthenia, but I think we have run out of time.
Thank you so much, sir. Such an elaborate topic and subtopics, but you covered it so beautifully and like amazing documentation and all the pictures and the videos, especially. Amitava sir, Pradeep Sharma sir, any comments before we go on for the questions?
It was splendid. I think it was an excellent presentation with that galaxy of cases that you have done with such good illustrations and documentations. Even prior to that, you showed the signs with the videos very illustratively. So it was really a wonderful presentation describing so many diverse cases. I think it will be a real boon for the postgraduates and all ophthalmologists in particular, even people like me. I have learned so much from that. So it's wonderful.
Sir, I have learned everything from you. Thank you. Thank you. So thank you so much.
It was most engrossing. I mean, I was totally hooked on that.
Thank you. Thank you, sir.
So only a couple of questions. First is, why is CT angio better than DSA for picking up aneurysm? I think you mentioned.
Yeah, that's I didn't say it was better. better. Digital subtraction angiography is the investigation of choice. That's what we have been traditionally taught. The problem with digital subtraction angiography is that you have to cannulate the internal carotid artery, and there is a 1% chance that you may be introducing a dissection of the internal carotid artery. So it has been shown in many studies. CT angiography is less invasive. You still have to give the contrast, but the contrast is given in the artery, but you don't have to cannulate the internal carotid artery. So there was a head-to-head on comparison between the digital subtraction angiography and the CT angiography, and the digital subtraction angiography scored over the CT angiography in that it did pick up some small aneurysm, but none of them were clinically significant. Like, they were not aneurysms which you would go and look at embolization or something. So CT angiography scores over DSA in being less invasive and a much safer investigation. DSA has a 1% chance of introducing a dissection of the carotid artery, which could be fatal, or it could end up with some morbidity like a stroke or something. CT angiography is less invasive, and it is also more widely available. So if you do pick up an aneurysm in digital subtraction angiography, which was missed on a CT angiography, it is not of any clinical relevance. So that is why I said CT angiography possibly is the investigation of choice. But CT angiography definitely is much better than MR angiography, because CT angiography is a dynamic technique. You are injecting the dye and you are watching the vessels fill. Whereas in MR angiography, whatever is flowing, only that you see. So less than 5 millimeter aneurysms won't be picked up. Thrombus aneurysms again won't be picked up. So that is the problem with MR angiography. DSA is the gold standard, no doubt about it, but it is more invasive. CT angiography is safer, and I mean, from a clinical point of view, possibly equally effective, more widely available also. DSA requires specialized equipment. CT angiography, most of our radiologists whom we sent for MRI scan, that was from Clarity Imaging Center. Dr. Murugan was kind enough to share it with me. So it is more widely available, more easily done.
I think mean 4-vessel angiography is the gold standard. But that's more invasive.
Right.
Next one is, what are the type of congenital fibrosis of extraocular muscle?
Yeah, so congenital fibrosis of extraocular muscles are of 3 types: CF, EOM 1, 2, and 3. By and large, a clinical and a genetic classification, a clinico-genetic classification. So the one that I showed was a unilateral fibrosis of the extraocular muscle. For the exam, you have 3 types: CF, EOM 1, 2, and 3. It is a clinico-genetic classification, so you need a genetic workup also. I'm not really updated on that. I had read it some time back. I cannot recall, but I think most of the genetic journals would have loads of information on them, and most of them are open access.
We will be having a separate talk on covering these aspects. Yeah.
So, and the last one, I think you showed a video of FDT and FGT. Can you explain the difference once again, as it is commonly misunderstood?
Should I be playing the video again?
So you can play. Yes, sir.
So you can see my slides?
Yeah.
Yes, sir.
Okay, so forced duction testing, like this patient has an elevation restriction. So we don't know whether the inferior rectus is tight and it is not letting the globe go up, or the superior rectus could be weak, which is not elevating the eye as it should be. So in the first step, we do the forced duction testing. You do it under topical anesthesia. Use a Pierce-Hoskins forceps. I forgot to tell that. Pierce-Hoskins is an atraumatic forceps, doesn't injure the conjunctiva. You have to catch the globe at the limbus where the tenons and conjunctiva are fused together. So that is where you get a firm grip. And for the vertical and horizontal recti, you lift the globe up because they're coming from behind the orbit. If you pulse the globe, what will happen is here, the globe is not going up. I ask the patient to look up. This is to relax the inferior rectus. This is to relax the inferior rectus. So ask the patient to look up and then try to push the globe up. This is the forced duction testing. So once again, ask the patient to look up, hold the globe at the limbus where the tenons and the conjunctiva are fused together. Ask the patient to look up to relax the inferior rectus and try to push the globe up, at the same time making sure that I'm not pushing the globe behind in the orbit. Note again, I'll play the video again. So I'm trying to push the globe up So I'm able to do it without much of an effort. The end point is that the lower limbus should cross the intercanthal line, which I'm able to do without much effort. So in this patient, the force duction testing is negative. There is no restriction. The inferior rectus of the left eye, which I'm testing, is not tight. So that is the interpretation for a force duction testing. Now for force generation testing, there are many ways to do it. You ask the patient to look up and try to feel the tug on the forceps which you are holding. So there was another trouble pulling the globe down. If the superior rectus is not generating any force, then I'll be able to pull the globe down without much of an effort. So notice this. So now ask the patient to look up. Patient is not able to look up, and I'm trying to pull the globe down.
I think Dr. Murli sir's internet is a little weak and breaking.
I'm able to do this test. Both the FDT shows no restriction. Oh, I'm sorry. So the interpretation of this test is that the FDT is negative. There is no restriction to elevation, and the FGT is also negative. That is, the superior rectus is generating no force. The superior rectus is paretic because I'm able to pull the globe down when the patient is looking. So did that clarify? Or
Yes, sir. Yes, sir. I think we have covered most of the questions. The others, I think sir has covered beautifully in his talk. So thank you so much again, sir, for your valuable time, spending your evening with us, and for that excellent talk. I ask Pradeep Sharma sir for the concluding remarks before we call it a night.
Thank you, Shefali, for moderating so nicely and covering up all the questions that were there. And I think it was an excellent talk by Murli. It is really a splendid one, which I think people will watch again and again to see the different types of cases that have been covered on this. I thank Dr. Amitava for co-chairing with me. And of course, thank you, Shefali, once again, and Dr. Santosh for giving us this feast here. Thank you all.
So may I just say one thing? Yes. I would much prefer that we use the word limitation in a more sense rather than restriction at the first go. Only when force duction test or saccades which have come to a halt suddenly with the leash phenomena, maybe then the restriction would be the more appropriate term. Otherwise, the limitation covers both a palsy and a restrictive pathology.
Correct.
Also, with the force duction test, it would have been, I normally tell my students that the other eye is what demonstrates to you whether the patient is looking in the direction of interest. So, for example, if I want to passively elevate the eye, sorry, if I want to passively elevate the left eye, I would have asked the patient to look up, and I should have seen the right eye going up, confirming to me he is actually looking up while I'm elevating the left eye.
The patient had an up-gaze palsy. No, a patient had an up-gaze palsy, sir. Patient had an up-gaze palsy. So both eyes were not going up.
It wasn't a monocular elevation
so both eyes were not going. Had an up-gaze palsy.
If he has a gaze palsy, of
no, sir. It was an up-gaze palsy.
Okay,
up-gaze palsy because of a midbrain lesion. So patient had an up-gaze palsy.
Up-gaze palsy. Okay, got that.
So,
okay. Thank you all. Yeah. For the next topic, Dr. Shefali.
Yes, sir. So next we meet on September 21st. The topic is Duane syndrome, etiology, classification, diagnosis, and management by Dr. B.V. Rao. So see you all on the coming Wednesday. Thank you so much, and good night, everyone.
Thank you, everyone. Terrific, Dr. Murli. I really enjoyed it.
Thank you. Thank you.